Okay, good morning, everyone. It's 8 o'clock, so we're going to get started. We're going to get over 30 people sign up, so thank you very much. Welcome to Cardiac Sciences Grand Rounds, and we have one of our own today to give us an interesting talk. So Greg is originally from Saskatoon, where he completed a degree in pharmacy and actually worked as a pharmacist before going to medical school. He went to the University of Western Ontario, where I was trained back in London, Ontario. He then came to the West in Calgary, and he did his training in internal medicine and cardiology here, and then completed an echo fellowship at the University of Virginia. He has been very active in the general cardiology and ICU, as well as echocardiography areas, and has been the director of our CICU since 2008. He is an assistant clinical professor at the University of Calgary, and again, will provide us with a very interesting discussion today. Just a reminder that we have a CME evaluation form available now, so please complete it. And if you have any questions, feel free to post them on the chat. So Greg, it's a pleasure to have you. Thanks for agreeing to do this.
Okay, I'll share my screen here, Carlos. Is that full screen there, Carlos?
Not yet. Just press the little slide thing there and you'll.
There we go.
Perfect.
Okay. All right. Good morning. Thank you, everybody, for joining us today. I'm going to talk to you about routine preloading with dual antiplatelet therapy in acute coronary syndromes. And I've entitled this Yes, No, Maybe, Don't Care. I'm hoping to convince you that we should care. So my objectives for this morning are to congratulate everyone for their excellent care, and then to go over a few cases that highlight the value of having M&M rounds. Based on those cases, we've had some discussions about changing things, and so we'd like to review some of the current literature and the guidelines, and then hopefully talk about next steps or a plan for moving forward. So easy to say, or goes without saying that obviously we thought we were out of the fire, but we're still in the fire. So thank you all for your continuing efforts and hard work, which looks like it's going to last for at least another 3 to 4 weeks. I've shown this data to a lot of you in previous presentations, but just to give everybody a pat on the back, that this is the 30-day in-hospital mortality after PCI. And you can see that we have the best outcomes in the country. And if you look specifically at higher risk patients, so these are patients undergoing PCI that either have STEMI or cardiac arrest or shock, our crude rates again are the lowest in the country, and we have the best outcomes. So on the one hand, maybe we don't need to change anything, but you know, sometimes things aren't as good as they look, and perhaps we're missing something. So I'd like to go through 3 cases with you that highlight some of the problems with routine preloading with dual antiplatelet therapy. Firstly, cases where the patient doesn't have an NSTEMI and they're misdiagnosed. Secondly, cases where they have heightened bleeding risk as a consequence of preloading. And lastly, treatment delays that occur as a consequence of being given either ticagrelor or clopidogrel up front. So this is a case from my clinic in High River, and the age group here is classic for High River, 88-year-old female, who I've actually seen before and followed, and she has a known non-ischemic dilated cardiomyopathy with an EF of around 30%. She never had any ischemic symptoms, didn't really have a lot of risk factors, so she never actually undergone an ischemic workup, but being treated as a non-ischemic dilated cardiomyopathy. She also has AVNRT and intermittently gets rapid palpitations, and it's been a challenge sometimes to manage that. She doesn't tolerate beta blockers, but we are able to control it with lower dose diltiazem. She has a known pre-existing left bundle branch block and has a background history of hypertension. So she came in to emerge with her typical palpitations that she said felt exactly like her known AVNRT, and she was lightheaded. She had no chest pain, shortness of breath, diaphoresis, or nausea. I'll show you her ECG, and you can see her troponin pattern. So that's her ECG, and post-adenosine, this is what she does. So again, pretty classic for her known AV NRT. I didn't see her, I wasn't consulted on her, but I'll show you her follow-up in just a second. But some learning points for our trainees, just reminder that you know, there is this concern about left bundle branch block being a STEMI equivalent. The reality is that doesn't happen very often. In fact, I think I can count on my one hand with one finger the number of times that I've actually seen that. Hemodynamically stable patients presenting with chest pain and left bundle have only a slightly higher risk of MI compared to patients without left bundle. So use your clinical and history taking skills. More than 50% of patients presenting with acute chest pain and left bundle to the emergency department or a chest pain unit will ultimately found to have a diagnosis other than MI, and most commonly it's either just age-related or an underlying cardiomyopathy. So this lady is diagnosed by the rural physician as having a non-STEMI based on her troponin pattern, even though she had no chest pain. She was treated with fondaparinux, and she was discharged on aspirin, ticagrelor for a year, and Lipitor. And it was recommended that she have a follow-up echocardiogram, which actually showed an improvement in her LVEF from 30 to 40%. So again, was this really a non-STEMI? And for all of us in cardiology, you know, this is one of the things that really drives us bonkers, right? Is the patient who has a positive troponin, but really has nothing else to suggest that it was an ischemic event, but because the troponin's positive, they have to be treated as such. I don't need to tell this audience all the things that can cause you to have an elevated troponin. They're listed here on the left. I think in her case, a tachyarrhythmia with an underlying cardiomyopathy is a good reason to have a troponin rise. And there are age-related differences in normal values. And I always have to remind people that we don't really know what a normal troponin is in someone who's 88, right? And so one of the common reasons, you know, we get consulted as an elderly person with an elevated troponin. So in that case, you know, she started on troponin. She didn't have any problems, but, you know, an 88-year-old lady on aspirin and ticagrelor for an extended period of time is not without risk. And I'm not going to show you data, but I think we all empirically know they're going to have some heightened bleeding risk. And I'm going to come back to misdiagnoses a little bit later. The second case is heightened bleeding risk. So this is a 70-year-old male who presented to one of the non-FMC emergency rooms at 2:30 in the morning, just after Christmas, had a background history of AFib, not anticoagulated, normal echocardiogram in 2018, hypertension, had a prior seizure disorder related to alcohol withdrawal, but wasn't currently drinking, and had some baseline renal insufficiency. He'd had chest and back pain on and off since Christmas, but because it was Christmas, nobody wants to come into hospital. His high sensitivity troponin came back at 5,000 plus. He became hemodynamically unstable in the emergency department, was started on a phenylephrine infusion, had a stat CTA looking for aortic dissection because he had a bit of component of back pain, which was negative. This is his initial ECG. You know, I think given the presentation in the ECG, you could talk about the value of the stat CTA, but certainly widespread concerning ST segment changes. This is what it looked like when his rate was slowed a little bit, and you can see he has persistent ST segment depression. So here's his emergency room medication list. And so you can see he kind of arrived just before 2:30, was given a stat aspirin. But note the time of the fondaparinux administration, 4:09 a.m. You can see he was started on a phenylephrine infusion even before that at 4:12. And you can see his ticagrelor was also administered at 4:15. And you can see the temporal correlation between the troponin results and the administration of fondaparinux and ticagrelor. Cath lab was called. They felt that there wasn't ST elevation, but something was going on, recommended acute transfer over here. The astute first-year cardiology fellow performed a V-scan evaluation, worried about a mechanical complication, and to his credit, diagnosed the patient with a probable ruptured mitral valve, had a formal echocardiogram that confirmed a rupture, interestingly, of the anterolateral pat muscle. Patient went to the cath lab, had an urgent angiogram and a balloon pump inserted, and then went for surgery that morning. And here's the operative report. Unfortunately, he was fully loaded with ticagrelor. These are his intraoperative blood product requirements, and as well as pretty brisk bleeding on day one in CVICU that gradually slowed. And he had a long and complicated post-op course, but did eventually recover and left hospital well. Again, I don't think I have to tell this audience that non-deferrable major surgery on dual antiplatelet therapy is a significant risk for intraoperative bleeding. And, you know, for those of you that are regular attendees at our cardiac triage rounds, you'll know that the most common question asked immediately after the age and date and presentation of the patient was, when did they get their last dose of ticagrelor or Plavix? Third case is one of treatment delays. So this is a 64-year-old female who presented to FMC on June 22nd, a year ago, and this was a case that was reviewed at multiple M&M rounds, both in surgery and CICU. This patient had a 2-week history of intermittent chest pain with no known history of coronary disease. Her initial ECG showed, again, subtle but fairly widespread ST segment depression with perhaps a hint of ST elevation and AVR. So again, in the emergency room, she was given aspirin acutely. You can see again the time delay between aspirin and fondaparinux, and simultaneously to the fondaparinux, she was given ticagrelor. And once again, I'll highlight for you the temporal association between the troponin results coming back positive and the administration of ticagrelor. So she was admitted to the CICU. Echo showed mild LV dysfunction. She became hypotensive in the afternoon with ongoing ECG changes. She had an urgent cath and a balloon pump was inserted. You can see her coronary anatomy is quite bad with, in essence, left main equivalent and an elevated LV-EDP. The recommendation was urgent surgery. So that evening, cardiac surgery was in to speak with the patient, but because she had been loaded with ticagrelor, the decision was made to defer surgery until either the next day or the day after. The on-call cardiology fellow got a call around 9 o'clock at night reporting an abnormal chest x-ray finding that suggested that there was quite an enlargement in the mediastinum. And you can see the x-ray there on the right, and it is quite abnormal. And there was concern there may have been a complication from an intra-aortic balloon pump insertion, which you can see the tip of the balloon pump there is a little low. But the concern was that there might have been a dissection. So the heparin was stopped and she was sent for a stat CT. The CT came back negative for dissection, but with the balloon pump off, she began to have more pain, hypotensive, began to look unwell. The patient was agitated, disoriented, showing signs of clinical hypoperfusion. There was concern that because there had been about 4 to 5 hours with the balloon pump off, there could have been a risk of thrombus formation on the balloon pump, so it was actually removed. Patient was transferred urgently to the CVOR at 7:30 in the morning. She arrested upon induction, required 20 minutes of CPR and had to crash onto cardiopulmonary bypass via the groins. She came off relatively uncomplicated bypass surgery with short cross clamp time, but required ECMO. And she languished in hospital for a number of months with a number of complications and unfortunately eventually died in August. So again, this is just a case to highlight the challenge when people have been loaded with ticagrelor from a cardiac surgery perspective. I just show you her ECG, again, from around midnight with the balloon pump off, showing, you know, fairly widespread ST segment changes. So these are the slide courtesy of my colleague Graham Wong from VGH, and Graham is on the line this morning. We're going to come back to some of the work that Graham's done at the end, but just again, a learning point for trainees. Left main disease and acute coronary syndromes is found in about 2 to 18% of patients. There's really no clinical predictors that are useful in identifying left main disease, obviously, and we look for ST elevation, which has a fairly high sensitivity and specificity but obviously we don't always see that. So this is from the European guidelines, and this is what we do when we see patients with acute coronary syndromes. We try to balance patient risks, which are in blue, which includes their clinical presentation, being either chronic cardiac syndromes versus acute coronary syndromes, and I would add in, non-cardiac chest pain scenarios. Include their comorbidities, and then look at their concomitant medications, look at their procedural aspects, and decide on what we think is the appropriate antithrombotic therapy. And I think the pendulum has shifted quite significantly towards ischemic risk compared to bleeding risk, particularly, in the setting of the emergency department and in rural sites, where I think there's an impression that if they don't give dual antiplatelet therapy, the patient is being inadequately treated. And I think we need to get the message out that troponin does not equal ticagrelor, or an elevation in troponin does not equal ticagrelor. And hopefully we'll come back and talk about that in a little more detail. So this is what we're trying to do on the left here. These are our drugs. We're trying to interfere with platelet aggregation in the setting of acute plaque rupture. And is there therefore a pharmacokinetic rationale for delaying preloading? Because obviously if it takes a long time for the drugs to work, we still have to consider it. But the newer agents, in particular ticagrelor, has a rapid onset of action. It doesn't require hepatic metabolism to its active form, so it's rapidly active within half an hour to an hour. So there is a pharmacokinetic rationale for delaying preloading with dual antiplatelet therapy. So what is the historical evidence for why we do this? These are the trials that were published in the early 2000s that led to the strategy of preloading. CURE in particular was published in 2001, which was a randomized controlled trial using clopidogrel with a preloading strategy. You'll note, however, that the median time to PCI after preloading was 10 days. Practice has changed quite a bit since then. And in fact, only 20% of patients in CURE actually underwent PCI. So they subgroup analysis of the PCI CURE trial, and I'll show you the results in a second. But, this is pretty historical data. This is me graduating from medical school at UWO in 1994 with my classmates. And so if I'm old, this data is even older because this is 2004. So if we look at the actual data, again, CURE was mostly medical therapy, and it did show a small benefit in reducing outcomes. But if you look at PCI CURE, which is the subgroup analysis of those patients that underwent PCI, and again, only 20% of them did, there really wasn't much different in mortality. CREDO was a study looking specifically at patients undergoing PCI with a preloading strategy. And although there was a subtle difference, obviously you see the confidence intervals are very wide. So there really is very limited data to support a strategy of preloading. This is more modern evidence, and this is in fact the only randomized trial assessing a strategy of preloading. So this is 4,000 patients with non-ST segment elevation coronary syndromes who had an elevated troponin, who were scheduled to undergo angiography within 48 hours. So reflective of modern practice where an acute invasive strategy or an expedited invasive strategy is chosen. They're randomized to either prasugrel at the time of diagnosis versus administering it in the cath lab after the coronary anatomy is defined. And the primary endpoint is a composite of death from cardiovascular causes, MI, stroke, urgent revasc, or use of a 2B3A bailout. And this is all of the patients on the left. You can see that there was no difference in the primary endpoint of cardiovascular complications. And you can see that there's an increased bleeding risk in the patients who underwent pretreatment of about 1.4%. If you look specifically at the patients that underwent PCI, there was no difference, pretreatment versus no pretreatment, And again, a heightened bleeding risk of about 1% in those patients that were preloaded. This is a subsequent study called the ISAR React 5 trial, which again was a randomized trial using a preloading strategy. They not only had differences in preloading strategy, they also chose 2 agents. So the thought was that prasugrel had been proven to be beneficial or at the time of definition of coronary anatomy. So it was chosen to be given in the cath lab, and ticagrelor was felt to be the agent that would be have the best chance of showing a benefit using a preloading strategy. So 46% of these patients were NSTEMIs, primarily done in Europe, 2,000 patients in each arm, same type of primary endpoint. Secondary endpoints were bleeding at 1 year. And you can see that on the right-hand slide here, which was the primary endpoint at 1 year, that there was a benefit of not preloading with ticagrelor, but rather giving prasugrel in the cath lab at the time of definition of coronary anatomy. Now, of the components of the primary endpoint, this was primarily driven by reduction in myocardial infarction, subsequent myocardial infarction. So I don't really know if giving prasugrel in the cath lab didn't change the outcome from the cath, but it reduced subsequent MI. So I'm not sure quite how to interpret that data other than to say that a preloading strategy did not prove to be any better. Importantly, and I think what we all worry about is what is the actual rate of in-stent thrombosis, because that's a concern if you're just giving your P2Y12 agent in the cath lab. Is it going to be absorbed in time? And there was no difference in definite or probable stent thrombosis between the 2 groups. And this is kind of the last nail in the coffin, so to speak, of preloading. This is an analysis of data from Sweden, basically using their equivalent of our approach database. And so they have a very large database of all patients with acute coronary syndromes that undergo PCI in the country. And it's been in operation since 2010 with a large number of patients. And based on European recommendations, this county, Västra Götaland, which includes the very large metropolitan center of Gothenburg, which has a population of around 1.7 million. So if you could consider that pretty equivalent to Calgary, and if you consider Swedes and Canadians fairly close in genetic makeup, I think we are looking at a similar population of patients. So in 2016, that region of Sweden switched from a strategy of preloading to not preloading. And so the number of patients with NSTEMI who were preloaded went from 99% in 2010 to down to 15% in 2018. So same group of patients treated at the same institutions by the same doctors. I think we have a pretty good example of being able to compare apples to apples here. And on the right-hand slide is the analysis of that particular subset of patients. So not all of the patients in Sweden, but that group from Gothenburg that underwent a change in preloading strategy. And you can see that there was no difference in death at 30 days, no difference in death at 1 year. No definite increase in stent thrombosis at 30 days, increase in in-hospital bleeding. And if you look specifically at the risk of reoperation due to bleeding in patients that underwent CABG, their risk increased by 33%, or a third, of needing to go back to the OR for bleeding problems post-op. So I think this is pretty compelling data, real-world data, looking at an equivalent population of patients treated in a modern fashion in a modern institution with modern techniques. So some interesting comments made in the discussion section of that paper. An alternative explanation for the lack of benefit with pretreatment strategy is that this therapy is futile under the current circumstance, with shorter time to PCI, use of more potent antiplatelet agents during and after PCI, and improved technology and operator skills. Therefore, pretreatment may be associated with more harm than benefit in the modern clinical era. The number of patients who are initially mistakenly diagnosed with non-STEMI in everyday clinical practice is substantial. Even in carefully designed and conducted clinical trials, the risk of diagnostic errors is surprisingly high. And in this particular acuity trial, which was a ACS study run by some, pretty well-known investigators, about 30% of included patients turned out to not have non-STEMI, which was actually an inclusion criteria for the study. So that's in a study environment. You can imagine, and we all know this from our clinical experience, what the reality is in real practice. What about the use of preloading in STEMI? There's only one randomized trial here called Atlantic, which did include some enrollment in Canada by Warren Cantor and Sean Goodman. And they randomized 1,800 patients with STEMI early onset to either pre-hospital versus in-hospital loading of ticagrelor. So they got loaded with ticagrelor in the ambulance by the paramedics. Primary endpoint was resolution of ST segment change and TIMI flow at the time of cath, which, again, really, we wouldn't expect the big impact of giving 180 of ticagrelor in terms of opening up the artery. But I think there was an important point here about secondary, and that was one of the secondary endpoints, which is in-stent thrombosis at 30 days, which I think, again, is something we would worry about, and we worry about in the STEMI situation, where people might be nauseated and throwing up. They might be in shock, so they're not perfusing their gut. They might have had out-of-hospital cardiac arrest, and they might be cold. And so, do they absorb their ticagrelor if it's given acutely in the cath lab? And there was a difference in in-stent thrombosis at 30 days between the two strategies that I think is actually clinically relevant. And so I do have some concerns about changing the strategy related to STEMI, but there are probably some important learning points about preloading that we could talk about where it might not be the best thing to do. Again, there wasn't much time difference here to show, a major difference in clinical outcome because it was only 31 minutes between the two groups. So based on the data that I've shown you, primarily the non-STEMI data, in fact, entirely the non-STEMI data, these are the most recent European guidelines, and AHA, ACC have not updated their non-STEMI guidelines since 2014, so there's nothing new there. And the Canadian guidelines, antiplatelet guidelines, haven't readdressed this issue. So these are the most recent guidelines published on this topic. And I would point out to you that the Europeans recommend against routine pre-treatment with a P2Y12 inhibitor in patients in whom coronary anatomy is not known. And importantly, an early invasive management strategy is planned. And by early invasive, we usually mean about 48 hours. We can talk a little bit more about that. So they actually give us a class 3 recommendation, right? Which means that it causes harm, and the level of evidence was felt to be pretty convincing. This is some wordage from the guidelines. Based on the available evidence, it's not recommended to pre-treat in non-STEMI patients in whom the coronary anatomy is not known and early invasive management is planned. And again, I've highlighted the early invasive management, and we can talk about that. As I said, 48 hours. I think in reality, as long as you're in an environment where you have people that can attend to the patient promptly and determine if they're having signs of ongoing ischemia, you're probably still in an environment where you may not necessarily need to give a P2Y12 inhibitor. But if you're at the South Campus here and it's going to be 4 or 5 days till you get a cath, we could debate that. For patients with a delayed invasive management strategy, pre-treatment makes sense, but you need to consider the bleeding risk of the patient and also take into consideration their presentation. As I've shown you, our current P2Y12 receptor inhibitors have a fast onset of action, thereby allowing loading dose administration after cath and directly before PCI. So there's a pharmacokinetic rationale or mechanism by which we would expect them to be effective if given in the cath lab. A routine pre-treatment strategy may be deleterious for a relevant proportion of patients with diagnoses other than non-STEMIs, dissection, bleeding complications, intracranial bleeding, and may increase bleeding risk or delay procedures in patients scheduled for CABG after diagnostic angiography. And that's the purpose of the cases that I've tried to highlight for you. So what are others doing across the country? This was a quick sort of email phone survey of my colleagues. done a couple months ago prior to presenting this data to the PCI group. And you can see there's quite a disparity of practices across the country, probably reflective of kind of what we have been doing. And so you can see that there really isn't a consistent approach. Kudos to Graham, who I believe is on the call this morning, for moving this forward more formally in BC. And Graham was nice enough to share with me his slides for discussion and what he has already circulated to his group in British Columbia. So these are proposed changes to their ACS pre-printed order set. And I like the way a lot of this is worded, Graham. So routine pre-treatment in ACS patients in whom an early invasive management strategy is planned and the coronary anatomy is not known is not recommended given the lack of established benefit. But if there's going to be a delayed invasive management strategy and you've used 24 hours, then it may be considered based on thrombotic and bleeding risk and likelihood of requiring urgent cardiac surgery in the next 5 days. So I just highlighted that on the right in capital letters. What about STEMI? Consider withholding P2Y12 receptor blocker when urgent cardiac surgery is anticipated. Again, that's hard to predict clinically at the time of presentation, but I like the way this is worded. As in cases of previously discerned coronary anatomy, so a patient who has had a cath that showed a lot of disease before, there's a higher likelihood they may need to go on to surgery. If they've got clinically significant valvular disease as a possible precipitant for their presentation, as we showed with the MR, those suffering mechanical complications of MI or hemodynamic compromise and or shock suggestive of multivessel coronary disease. And I think this is a really important message for our emergency room colleagues, that if someone is unwell, hold off on the ticagrelor until we have a chance to weigh in on what we're going to need to do. What about fibrinolytic therapy? Consider withholding clopidogrel when urgent cardiac surgery is anticipated. Again, the same sort of guidelines, which I think are again reflective of important clinical clues that the patient might need surgery. Clopidogrel does not increase the initial success of fibrinolytic, but may improve the likelihood of culprit artery patency if fibrinolysis is successful. So that's a lot of data, which I hope summarizes kind of the status of where we're at, and importantly, what are the next steps. So again, I just want to highlight a process here that I think worked. We have M&M rounds on a routine basis to make sure that if there are systematic problems with what we're doing, we have the opportunity to change the system. And so again, I'd just like to highlight the value of having M&M rounds. They're often difficult and sometimes unpleasant, but there's a value to them. And I think, you know, these cases highlight that value. Again, we're doing well. You know, our mortality is very low, but I still think there's an opportunity to make some improvements. So what are the next steps? These are tough choices, but my options, or my proposed options, are we don't change anything, but we kind of, when we're in telephone consultation or in-person consultation with colleagues in the emergency department or rural sites, we sort of softly tell them that they don't necessarily need to pre-treat. The problem is usually that decision has been made by the time we're consulted, because again, I think there's an impression that they have to preload, otherwise the patient's suboptimally treated. Second option is a soft change, which I would propose is education via formal round Zoom conferences with our emergency room, internal medicine, and rural colleagues to reinforce some of this data and to let them know that troponin positivity doesn't always mean we need to give ticagrelor. And if we're going to be, you know, the vast majority of these patients are going to be consulted to us one way or the other, why not wait and let us decide? There's no loss in outcome if temporarily you delay preloading. And the last one is kind of what Graham has undertaken in BC, which is to try to rewrite provincial ACS guidelines and order sets, which obviously is a much more complicated process because it would involve shareholder input from Edmonton and other sites across the country. So I'm going to stop there, and I'm glad to take any questions and entertain comments from others. Graham, thank you for joining. Maybe I'd ask you first if you had any additional comments based on your experience.
Thanks, Greg. First of all, thank you very much for inviting me, and it was a great talk. I guess it's coldly comforting to know that we all share and struggle with the same issues and problems. I think you've laid out the issues quite nicely, and you know, we've had many challenging cases in which the P2Y12 inhibitor did influence the outcome. And in one case, we think contributed to mortality from the bleeding risk. So we made the decision regionally to address this, especially given the new ESC guidelines and recommendations from that particular body. Our order sets were developed after pretty broad stakeholder engagement. There's usually about 20-25 people that chime in, including regional ER, interventional cardiology, and cardiac surgery. So this was the work of quite a lot of people chiming in. We just got the orders approved Thursday, and it makes my job a little bit harder because now I have to get on multiple Zoom calls to regional ER and the different peripheral sites. But I think it's hard work that needs to be done. I think that it reflects the change in how we view ACS and how we manage it for the reason that you really elegantly outlined. So, you know, it's challenging work that I think that needs to be done, but I think at least our cardiac surgery colleagues were quite appreciative of that.
Thanks, Graham. I just perusing the chat box while you were speaking, and some good suggestions. Naren Scott Douglas from Nephrology posed the question, does your chance of getting an early cath really depend on what hospital in Calgary you present to? If so, this is very concerning. Access to cath should not be allocated on patient characteristics independent of which Calgary hospital they present to. That was a mild slight and an error on my part, Naren. No, there really isn't a difference. The reality is that sometimes patients do have to wait a few days just because of workload, and one of our cath labs being down at the moment. So there's no difference geographically, other than if you're physically at the Foothills and there's an opportunity to sneak somebody in, it's a lot easier to bring them up from the 8th floor than to have to get them across the city, but there is no difference in access. Vikas, I'll let you maybe pose your question yourself if you want.
Sure.
Yosef, maybe I'll just answer Yosef's question
Can you
first.
hear me okay?
Yeah,
Yep.
I'll just answer Yosef's question first, if that's okay, Vikas. But Yosef asked, query medical management and elderly with ACS. Again, for medical management, where you're not pursuing an early invasive strategy, there probably still is a benefit of P2Y12 inhibition. That, again, is the historical data from CURE showing benefit in that patient population. Again, taking into consideration their bleeding risk, and more importantly, making sure that their presentation is actually compatible with an ACS and not a troponin elevation from an alternative cause. So Vikas, why don't you go first, and then I see there's a question from Bill, and maybe Bill, you'd like to make a comment from a cardiac surgery perspective, but we'll give Vikas the microphone first.
Sure. Thanks, Greg. That's a great talk, and it's something we often talk about as implanters. Although, you know, not as a big surgery as cardiac surgery, we do find when we're putting in pacemakers that if they're on, especially dual antiplatelets, or if they've been given sort of other you know, fondaparinus, things like that, there is obviously more bleeding risk and hematoma risk. And the big issue with the hematoma is it increases your infection risk with the device. So, you know, whether you reoperate or not, or you leave the hematoma, it does increase that risk. And what we find is sometimes, you know, people come in with what looks like complete heart block. You know, there's no real evidence that there's any ACS going on, but a lot of times they get treated as the ACS because that's maybe what people are used to doing. And then, when they come for the permanent pacemaker, obviously there's a slightly higher risk of bleeding, especially if it's like the very next day or something like that. So I think sometimes maybe it has to do with junior learners, or maybe people who are new can extenders, where maybe it's easier just to follow the same kind of protocol, saying, oh, anything that comes in just treat as ACS, because then nobody's going to yell at you the next day. Because certainly I can't even track down who the person is to yell at them, so it's not going to happen. So
it's
yeah,
very true. It's very true. And again, I think there's a perception that you're disadvantaging the patient if you don't preload them, that somehow you're increasing the risk that their plaque that becomes unstable is going to cause them problems. But the vast majority of patients in that environment are given some form of heparin and aspirin, so they are protected already. But as Sandeep commented in the chat box, it's an education process, right? And it will be a long education process, because it's 20 or 30 years of practice pattern we're talking about changing. Bill, maybe you could make a comment from the cardiac surgery.
Yeah, thanks, Greg. And I just want to applaud again the work you're doing on this. I think that you've brought up the two areas of the kind of unstable patient, et cetera, and then the ones that are kind of more in quotes regular, right? So that maybe you have to kind of fine tune which group you'd go after first, right? I think I got interested in this from the point of view of the unstable patient, the one with the balloon pump, had ticagrelor, and those patients, I think my personal experience is more of those patients at Foothills should be operated sooner. More of them should be operated sooner than, okay, we just can't operate because of ticagrelor. The ones that are stable waiting on the ward, maybe it's not such a big issue. It's just more hospital beds, more waiting, more difficulty, this, that. But those patients that have some hypotension, mild shock, and if that group, I think we could help that group more. I mean, I know that group is a lot smaller in numbers, but I think we could help that group more. And a couple of your case presentations show that. I mean, and then I guess it's a no-brainer, but all of my colleagues kind of feel the same way when I brought up at a division meeting. So again, I mean, any help I can give as a surgeon, I'd be willing to help spread this out, whatever you think I can do. I applaud your work. I hope we can make some headway.
Thanks, Bill. There's a question in the chat box from one of our cardiology fellows, or Grant. I'm not sure which one of you asked the question, but practically how many NSTEMI patients actually go for cath within 24 to 48 hours? It's a good point. I think I'll make a comment, Brian, and then I'll let you take over. But again, I raised the issue that it maybe not specifically the time frame, but rather that they're in an environment that goes along with an early invasive strategy. So yes, the cath is the core part of an early invasive strategy, but along with that is an environment where the patients are being followed and looked after by experienced clinicians and nursing staff that can recognize signs of recurrent ischemia, because that's really what we're trying to prevent with all of this, right? And so, maybe the patient doesn't go for cath within 24 hours, but they're in an environment where people can identify if the person is having ongoing signs of ischemia. And if that is the case, 9 times out of 10, we can expedite their cath to the point where they are attended to promptly. Brian Har, you wanted to make a comment?
Yeah, thanks, Greg. And again, we appreciate that you had presented this as well to the interventional group in advance and went over things with us. You've clearly put a lot of time into this, as well as with Dr. Wong as well at NBC. So we appreciate your work both at a local and a national level. So for the ticagrelor piece of it, my first comment is that Alex Gregory, Mohammed Hassan, and I just got approval to start this week, actually. So I presented this at Ground Rounds last month. So we're going to be doing the reverse it trial. So we'll be keeping a close tabs on the CD surgery rounds. So this is a ticagrelor antibody that will bind ticagrelor. So that will potentially help with at least one piece of the puzzle for the STEMI patients that come in with surgical anatomy that got ticagrelor. It does not help with clopidogrel though. And also will help in patients that develop a bleed as well that have gotten ticagrelor. And second as well, one thing to emphasize, because I've noticed there has been some confusion intermittently about what type of ACS this applies to. So again, and I think you made it pretty clear in your presentation, but there is still benefit in STEMI patients, unless we suspect we are in a fine left main or multi-vessel disease. But more importantly, that not doing the ticagrelor or clopidogrel applies in particular for the non-ST elevation ACS, so unstable angina and non-STEMI. So I just wanted to emphasize those points to the group.
As Sachadina asked, do you think there's a role for cangrelor? I always have trouble saying that in the STEMI population. So cangrelor is an IV P2Y12 receptor inhibitor, obviously very fast acting. I don't believe it's available in Canada. Correct me if I'm wrong,
It's not.
No, it's not available yet, but there's some interest in potentially having it approved here as well. The onset's 2 minutes, and once it goes off, platelets return to normal function within an hour.
So Greg, let me ask you something. So, it's good to just remark that in the first case, that lady, you don't get rid of her AVNRT. She's going to continue showing up and they're going to continue treating her as an ACS. So that's a very easy fix.
it's already been referred.
88 years old is not a contraindication for a slow pathway modification. It has a 99% success rate. So I remind people that we can actually cure those things. And the second patient had atrial fibrillation, so also an arrhythmic case. So anyways, let me ask you something. So overall, despite all the data you showed and the fact that there's more bleeding, I didn't see in any of the trials any true signal of increased mortality with this bleeding. What do you think that is?
Well, a lot of the bleeding, you're right, is probably surgical, which Bill and colleagues deal with. So it potentially delays their discharge. They have more time in hospital, but might not be necessarily associated with mortality. And, again, reflective of clinical practice, what do we see? We see nosebleeds, we see genital urinary bleeding, we see GI bleeding. We don't very often see catastrophic intracranial hemorrhage, but, those cases are out there. I'm sure elderly people who fall on dual antiplatelet therapy are going to have complications, even if it doesn't necessarily show up in a clinical trial. So, again, I think the point, Carlos, and I think we all know this, right, that if there is no benefit of giving the drug, so it's being given because of an elevated troponin, and even if there is relatively small harm, there's still harm and there's no benefit, it shouldn't be given, right? And I think what the data is pretty clear about right now is that we're not losing anything by deferring administration of ticagrelor or clopidogrel. And I think that is the part of the practice that we need to shift, right? That historically there's been this impression that we have to give it up front, and the sooner you give it, the better off the patient is going to be. And I think the message that we need to get out is you can wait, and we're not losing anything by waiting. And if you're not sure, consult us. And again, I was laughing with Dean. I was on at the South a couple of weeks ago, and patient came in with an ACS, a trope elevation of 50, had no real ECG changes, but a good story. Had the usual cocktail. I carried on with the ticagrelor, sent them up, and the patient had left main disease. Now, patient was stable, didn't have to go to surgery right away, waited 48 hours, 72 hours. Bill and colleagues operated on him, and he did fine. So there's lots of patients where we're going to continue with current strategy and nothing bad is going to happen. But as we've highlighted, and I think as all of us have seen, and Graham has seen, and all of my colleagues across the country similarly have seen these cases where unfortunately bad things happen. And so I do think there's a value in changing the strategy, even though you're right, Carlos, in the sense that perhaps some of the bleeding isn't associated with increased mortality. It's certainly associated with delays and longer stays in hospital, and it's certainly associated with delays in treatment strategy, as we've all been privy to when we go to heart team rounds.
Oh yeah, well, I wasn't implying that. What I'm trying to get is that actually, if you look at the Sweetheart data, the absolute increase in risk of bleeding is 1.2%. So if you look at the number needed to harm, is actually pretty small by giving this. So my point is that actually, yeah, you shouldn't be giving these drugs to these people, because the number needed, you are going to harm more people than benefit. Probably you not going to kill them, but that doesn't mean that this is not an important practice to do. So by looking at that, large registry, you can actually make the calculations, which I actually made here, and it's very important to keep that in mind. So I think that it is a great input to try to avoid these drugs in these patients with non-STEMI. Now, one of Graham's slides showed that risk of bleeding, and how are you guys actually stratifying the risk of bleeding? Are you using any risk scores? There's always this talk about these risk scores. What is the best way of trying to risk stratify these patients?
Graham, do you want to tackle that one?
Question. I'm not sure that there is a great bleeding score that would tend to sort of magically pull out all the patients that you think are bleeding. We tried in the text of our proposed changes to sort of highlight some of the clinical features that in the past have been associated with a high likelihood of needing to go to the OR quickly, rather than focus on actual bleeding risk. The same people who are at increased thrombotic risk tend to be the same people who are at increased bleeding risk. So we didn't think that focusing on that would necessarily help us get out of the soup, but it was trying to focus on the people that you think needed to go to the OR sooner rather than later, which is why we put an emphasis on some of the clinical features that we listed on our strategy. But it's tough sometimes to figure out who the bleeders are. But we tell our residents, your poster child is your little old lady with a high creatinine, but people without those features also bleed as well.
Great. Any other questions there, Greg?
Just a question from Joseph. I'm not sure Joseph exactly can use DAPT in acute pericarditis caused pericardial hematoma. So, good point. A situation where oftentimes patients present with chest pain and have elevated troponins, and yes, giving dual antiplatelet therapy to that patient can increase their risk of developing tamponade. So, just a good example of a situation where a misdiagnosis can lead to problems with routine administration of DAPT.
So do we have a strategy to discuss this with our ER rooms and make some medication and changes on this? Have we looked into that? Should we just start working with?
Well, the first step, I felt the first step was to talk to the PCI folks and make sure that from their perspective, this wasn't going to be problematic. And Brian and colleagues were in support of trying to make some change. And then I wanted to present to our group to make sure that the division members were happy with trying to make a change. And if I get the good housekeeping seal of approval from our group, then I think we move forward. My proposal was to start with a soft approach, and then we'll have the longer term strategy is going to occur potentially at your level, Carlos, with our colleagues in Edmonton to decide, if we want to formally do something like Graham has done, but at least to start with, start to having some rounds, give this presentation to our eMERGE colleagues and some of our rural and internal medicine colleagues at the other sites, and at least start to disseminate the information that it is okay to think twice about giving dual antiplatelet therapy.
No, I think that's a great idea. And I think we've got a golden opportunity with the Connect Care implementation to maybe use some of Graham's examples to try to implement here also. So I'm all for it.
We'd be happy to share anything that we've done here in BC with you guys.
Thanks, Graham. That'd be great. No, yeah, I think that, we are all in agreement that, you've showed plenty of evidence that it's time to rethink what we do within STEMI patients. And it should be a relatively easy, doing less something sometimes is better than doing more. And I think that there's no doubt that you've showed, and, the European Society guidelines are pretty strong in that sense. And, Graham and the team in BC has done a great job. So I think we could do this. So thanks for reviewing this important topic. And I think the next steps, we will need to talk with the Edmonton people and maybe involve also emergency people here and work around that. I think, we had over 70 people from the division here today. So I think that there's pretty much agreement that we can implement this among our group. I don't know, any other recommendations, Greg?
No, that's great, Carlos. Thank you. And thanks everybody for your support. And we'll keep people informed, and let me know if offline if people have additional comments.
Okay, thanks, Greg. That was a great presentation. Don't forget to complete your evaluation forms, and we'll see you next week. Thanks, Graham, for joining us.
Bye, everybody. Have a good day.